Hello, everyone, and welcome to Ingenious Talks Online, Cartilage and Osteoarthritis, Biomechanics, and Medical Image Analysis. Thank you for joining us today. My name is Laura Kilpatrick, and I'll be serving as the moderator for today's event. While we meet today on a virtual platform, we would like to acknowledge the Algonquin Nation, whose traditional and unceded territory we are gathered upon. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. Together, please consider how we are and can each, in our own way, try to move forward in a spirit of reconciliation and collaboration. So now we'll review a few event items. So this is a Zoom webinar, and therefore all attendee microphones and videos have been muted and disabled. However, there is the option to ask questions by typing in the Q&A box on your screen. While questions will be answered at the conclusion of the presentation, we highly encourage you to type them as they come to mind into the Q&A box on your screen. So you do not need to wait until the question and answer period to submit your question. We will try to get to as many questions as possible, but please be mindful that with a high volume of questions, we cannot guarantee that all will be answered. You may also type in the chat box on your screen to talk amongst each other and share ideas. And finally, a brief survey will appear on screen at the conclusion of the webinar. And if you do have the time, we'd really appreciate if you could fill it out. We really appreciate your feedback. Answers are anonymous. So now I'm pleased to introduce to you our speaker, Dr. Andrew Speirs. Dr. Speirs is an associate professor in the Department of Mechanical and Aerospace Engineering at Carleton University, where his research focuses on cartilage, osteoarthritis, and medical image analysis. Using a combination of medical imaging, computer simulations, and in vitro laboratory experiments, he investigates the causes of osteoarthritis from the macroscopic scale of human movement to the microscopic scale of cellular micromechanical environment. This approach attempts to link the forces generated in articular joints during daily activities to tissue microscopic damage and changes in cell behavior that lead to osteoarthritis. Today, Dr. Speirs will describe the fascinating behavior of cartilage as a material and its ability to provide low friction motion under large forces. He will also discuss collaborative research with clinicians at the Ottawa Hospital involving medical imaging, computer simulation, and lab testing, which is helping us understand the mechanisms causing arthritis and how it may be treated. Future directions involving tissue engineering will also be presented. Thank you, Dr. Speirs, for joining us today. And now I hand it over to you.
All right, good afternoon, everyone, and welcome to this talk on osteoarthritis. So I'm going to start by saying, whenever I tell friends and family that I do arthritis research, they always ask me what the cure is. So I'm going to start off by saying we don't actually have a cure at the moment, but through collaboration between engineers such as myself and, I work with orthopedic surgeons and radiologists, we are making advancements in our understanding of what happens in degeneration and what leads to degeneration in the first place. And that can hopefully help us, prevent degeneration from occurring or develop better treatments. Okay, so arthritis is the #1 chronic condition in Canada, in fact, in many countries such as the United States and Europe. And it affects quite a large proportion of the population. Now, these numbers include all forms of arthritis, and we can divide that into osteoarthritis and inflammatory arthritis, which includes rheumatoid arthritis. But most of these cases are actually osteoarthritis. And you can see the numbers here for Canada, and you can see that as we age, arthritis becomes more and more common, and a lot of these are due to osteoarthritis. And we think of osteoarthritis as a kind of wear and tear on our joint that affects primarily cartilage, although as we'll see today, it affects other tissues within the joint. So as we age, there's just more and more wear and tear on our joints, and more people experience osteoarthritis symptoms. And it's expected by about 2040 that 9 million Canadians will suffer from some form of arthritis. And really the only effective treatment we have right now, especially for more advanced stages of arthritis, is a total joint replacement. So you can see here the numbers of hip and knee replacements. These are the most common joint replacement surgeries that are done. They account for about 140,000 surgeries every year in Canada, and they're increasing, and they'll keep increasing, especially as our population ages. So what is osteoarthritis? So as I said, we really think of it as wear and tear on the cartilage, leading to cartilage damage. And you can see this sort of an opening of the knee joint, that the cartilage gets worn away. And in more advanced cases, we end up having essentially defects or holes all the way through the thickness of the cartilage, leading to bone-on-bone contact. Now, arthritis is usually diagnosed with x-rays because they're fairly cheap and quick to do. We can't actually see cartilage on x-rays, but we can infer what changes the joint has undergone. So on the left x-ray here is a normal knee, and you can see that there's a nice gap between the two bones. So the top one is the femur or the thigh bone. The bottom one, the bigger bottom one, is the tibia, and then the fibula is the smaller one next to it. But we can see that there's a nice gap between the bone on both sides of the knee. Whereas in this X-ray on the in the middle of the slide, one side of the knee, you can see that the gap is a lot thinner, and that's tells us that the cartilage has worn away, and in fact, this patient may have bone-on-bone contact. So we call that joint space narrowing. I'm going to talk about how cartilage behaves, normal cartilage behaves, the type of change it undergoes in degeneration, and then how we can study that. So this is showing a cross-section of the hip joint. So the hip joint is a ball and socket joint, and this bottom bone is the femur. We call this the femoral head, this sort of spherical portion. And then the socket is the acetabulum, that's part of our pelvis. And shown in blue here, it's a thin lining of articular cartilage. It's usually about 1 millimeter or 2 thick. So it's not a very thick tissue, but it's very, very important for the function of our joints, and especially maintaining very low friction as we move about and place large forces on our cartilage. So as we move about, this may not be intuitive or obvious, but in our hips and knees, mostly due to the contraction of our muscles, we generate forces of about 2.5 to 3 times of our own body weight every time we take a step. And we might take 1 to 2 million steps every year, depending on how active we are. And so that generates a lot of cyclic forces and very high loads on that cartilage. And it has to provide that very low friction rotations of our joints, ideally throughout our lifetime. And the composition of cartilage is sort of optimized to provide this low friction load support and motion in our joints. And it's made up of mostly water. So about 3/4 of the volume of our cartilage is water. And then there's very large molecules, protein molecules, that make up our tissue. So the more important ones in cartilage are collagen and proteoglycan. So even though the proteoglycan only makes up about 5% of the volume of the tissue, it's very, very important for its function in terms of how it interacts with the water. So in the middle here, you can see it's an electron microscope image of a proteoglycan molecule. So you can see it's a fairly complex molecule. And over here on the right, you can see schematically what these look like. So the proteoglycan is this sort of, it's got a thin backbone molecule, quite long, and then sticking out the sides of it are these sort of bottle brush-like structures. And the bristles of these bottle brushes are called glycosaminoglycan molecules, or GAG molecules. And the water molecules sort of sit in the spaces between these molecules. So what happens when we load the cartilage in, either as we walk about, or we can take cartilage samples out and test them in the lab. So cartilage itself is actually, it's very well adapted to holding on to water. So when we squeeze it, it's like a sponge. We can squeeze water out of it. Or another analogy might be, if we're walking along the beach and we're walking along the sandy beach that's saturated with water, when we take a step, we actually put pressure on that sand and that squeezes the water out. And that's why we see this sort of dry spot around the foot. And then when we take the foot away, the water rushes back into that spot. And you can see where this person has already walked, but they're no longer stepping there. There's water back in that sand. So cartilage works quite similar. And in fact, the way we model it in engineering, or the way we study its behavior, is that it's actually adapted from soil mechanics. And so when we place a force on our cartilage, so this could be, our 2.5 times our body weight as we're walking around, we squeeze the cartilage. We can't actually compress the water. We can't change its volume. So in order for that cartilage to be squeezed, the water actually has to flow out of the cartilage, or at least flow out of where we're pressing on it. And that's what you see on this sort of sandy beach. But cartilage is actually better than the sponge or the sandy beach at holding on to water. So one of the reasons for that is that the water molecules sit within those spaces between the larger protein molecules, and they have to sort of follow a very interweaving path to escape from that, and that kind of impedes the flow of the water. But also the end of these bristles, these gag molecules, have a negative charge on them, electrostatic charge. And the water molecule, this H2O that you see here, is dipolar. So out at the hydrogen end, it's slightly positively charged. At the oxygen end, it's slightly negatively charged. But we get this electrostatic attraction between the negative charge on the gag molecule and the positive charge on the hydrogen end of the water molecule. And that actually helps hold the water inside the cartilage tissue. And also, when we remove the force and the water, there's water at the surface, this actually helps draw the water back into the tissue. And so in practice, when we apply our force, either in our body or in the lab, instead of the cartilage compressing, since the water flow is impeded, it's actually quite difficult for the water to flow through cartilage. Instead, it generates a pressure. And ideally, this water pressure is enough to support this force, and the cartilage doesn't compress at all. So this is actually quite an important concept for why cartilage can provide such low friction. So in practice, the pressure won't completely balance or support this force. What actually happens is we get a little bit of compression of the cartilage. And so we can kind of divide cartilage up into a fluid phase and a solid phase. So this is how we analyze it. So the 75% of the cartilage is fluid, and we get a fluid pressure in that. But the solid phase, which is made up of those proteoglycan and collagen molecules, we can think of like a solid material. It's got pores in amongst it, but we can kind of treat it as a solid, and it'll generate a stress as it's compressed. So there's some balance between the fluid pressure and the solid stress, and that the sum of those two, we know from Newton's laws and equilibrium, that the sum of these two, fluid pressure and solid stress, will balance this force. We actually think of it as a contact stress, as a force per unit area. But when we want to think about friction on the surface of the cartilage, so if we had another cartilage surface pushing down on it, and then we rotate our joints, of course, we have sliding. The friction that occurs at that surface really only depends on how much this solid stress component is, right? So this fluid that we can kind of lock in at the surface of the cartilage allows it to be, a lot of it is of that sliding it's kind of water sliding against water, and that essentially has negligible friction. So the friction depends only on this solid stress. So the higher we can keep this fluid pressure, the lower we keep the solid stress and the lower friction we have in our joint, right? So with healthy cartilage, this fluid pressure makes up about 98% of this total sum, right? So that means only 2% of this applied force per unit area gets transferred into a solid stress, and the friction only acts on that part. In degenerated cartilage, as we'll see later, that balance kind of shifts more towards the solid stress, and so friction actually goes up and actually sort of accelerates the wear and tear on the joint. And we can We can analyze this in the lab. So this picture on the left, it's showing a small machine that one of my PhD students developed. So there's a motor here and a we call it a translation stage, so that allows this this kind of tower here to slide back and forth. And over here, there's an indenter pushing down on cartilage. You can't really see the cartilage specimen here because it's inside a water bath to keep the tissue hydrated. But there's sort of a spherical or hemispherical end on that can slide across the surface of the cartilage. And we can apply small weights here. And basically what we're aiming for, the weights are very small compared to what we have in the body, but we're also dealing with very small contact areas. So we try and balance it out so that we have the right kind of contact stress comparable to what we would see in the body. So we can test this in vitro, so in the lab on actual cartilage specimens, but it's not practical to measure what's actually happening inside the cartilage. So in order to do that, we develop these computer simulation models that simulate what we're doing in the lab, but allow us to investigate what happens inside the tissue. And so this demonstrates how the cartilage behaves kind of biomechanically. So when we start off, we can apply a constant force, compressing that indenter into the cartilage. So this top rectangle represents the cartilage, the AS is the articular surface, and then this bottom rectangle just represents the bone, or we call it the subchondral bone, the bone that's immediately underneath the cartilage. So if we apply a constant force, cartilage, it doesn't behave like a lot of normal kind of engineering materials in that it doesn't deform instantly. We'll get a small deformation or indentation initially, and then as we hold that force constant, the indenter will slowly migrate into the surface of the tissue. So when we see this minus 20% strain, that means that it's moved about 20% of the way into the surface of the tissue, right? So that's just holding the constant force, and it'll reach that after about half an hour. That's sort of typical of cartilage. And the blue curve here was the experimental value, what we measured on our cartilage specimens. The green is our computer simulation of it so that we can reproduce what's happening. And then the red line represents more what happens in our arthritic cartilage. So for the same amount of force, that indenter will actually go further into the tissue, and we'll see why in the next few slides. But interestingly, what happens is, when we move about, we're not applying just a compressive force. Our joints rotate. So that means we have some sliding at the surface. And when we simulate that in this experiment, it's actually quite interesting to see that even though we're still applying this constant force, the indenter starts to move out of the cartilage. And the reason for that is due to this water, the interaction of the water and the proteoglycan molecules. It's actually, as the slider moves away, so it's not in the same position. So we can see here in this image, the indenture is kind of in the middle of the cartilage, but as it slides over, let's say over to the right side, water will actually get sucked back in behind the indenter, and it'll restore or partly restore the thickness of the tissue. And then over time, as we're sliding back and forth, so from this time point here where the curve starts to increase, we're sliding back and forth at a few millimeters per second, and it'll actually regain its thickness almost back to kind of normal. And that's so this concept of sliding and tissue rehydration is over the, as we walk about and apply many cycles of forces and rotations, this is important for maintaining this tissue hydration and therefore very low friction. And so this is a small video of the computer simulation of what we just saw experimentally. So I'm going to run this just for a little bit, and then I'll explain what's happening. Sorry, I'll just. So what's plotted here is the pressure in the fluid. And we can see that this gray sort of hemisphere is the indenter, and the blue region is the cartilage. And these color contours are indicating how much fluid pressure there is. So up to about 300 kilopascals or 0.3 megapascals. We see immediately under this indenter, but as it slides to the side, there's no pressure anymore. So back here where it was initially loaded, near the center of the specimen, there's the pressure drops to 0 again, the fluid pressure, and that actually allows the fluid that's in the bath, it's not depicted in this picture, but it'll flow back in underneath, and the tissue kind of springs back to its normal thickness. Okay, so cartilage doesn't have any blood supply in it, but it does have a lot of cells inside. And so in this top microscope image in the center of the screen here, we can see a microscope image of a section of cartilage, and this is kind of turned sideways. So the articular surface is on the left, and the bone is kind of over here on the right. And these little black dots in the image are cells. They're known as chondrocytes. Those are the cells that produce the collagen and proteoglycan to help maintain the tissue. But because they don't have a direct blood supply, they have a relatively low nutrient supply, and so their metabolic activity is quite slow. And so that's one of the reasons that cartilage does degenerate, is because that if there is any wear and tear, the chondrocytes aren't active enough to actually repair the tissue. In other tissues like bone or muscle, they have a lot more blood supply, they're a lot more metabolically active, and they can repair the tissue and try and prevent damage more readily. But this is the result of from one of my master's students that finished a few years ago. The sliding is actually very important for helping to deliver nutrients. So most of the nutrients come in from the synovial fluid, so in through the surface of the cartilage. There's some evidence that it also comes in from the bone, but most of it does come through the surface. So it's actually been found that if you just stick cartilage in a bath that contains nutrients, they won't diffuse into the cartilage very easily. And what we looked at here, this middle image of the cartilage, is we used a fluorescent tracer attached to molecules that are about the same size as nutrient molecules. They weren't actually nutrient molecules, but they're the same size. So they would behave in terms of diffusing through the cartilage in much the same way. And this bottom image in the near the top of the screen is the two images overlaid. So the brightness of the green here is indicative of the concentration of these nutrient sized molecules after a certain amount of time. And we looked at these two different loading modes. So, we think about loading of our cartilage surfaces as just cyclic loading. So up and down, as you see here in this over on the left-hand side of this this bottom image. And so we applied this cyclic loading. And then we also looked at, well, what happens if we also superimpose this sliding back and forth? And this actually makes a big difference in terms of these nutrient sized molecules getting into the cartilage. And so these are results plotting the concentration of these molecules through the thickness. So just like in the picture of the microscope image, the articular surface is over on the left side of the graft. The subchondral bone is over on the right side of the graft, and then the y-axis here is proportional to the concentration of these molecules. And what we can see here is if we include the sliding, we can actually drive these nutrient molecules into the cartilage much more easily than just with this uniaxial compression. Also, I'm not showing it here, but if it's just put in the water bath with no loading whatsoever, you get almost no migration of these molecules into the tissue. I'm going to come back to this concept a little bit later when I talk about some clinical applications, because it does actually help explain some successes that were noted back in the 70s, but weren't really explained very well. So I'm going to leave it for now, but I'll come back to this concept a little bit later. So what happens when cartilage actually degenerate? So this is an image of, again, another microscope image, but we've applied a dye here to the microscope section. And as you see here, it's a bright red dye, and it actually binds to those proteoglycan molecules in proportion to the amount of proteoglycan molecules here. So essentially the brightness of the red is indicative of the concentration of those proteoglycan molecules. And so the articular surface is up here at the top of the image. It's quite common to have a small layer of cartilage that has no proteoglycan or almost no proteoglycan. And you can see again, all these little dots are the cells within the tissue. So this is taken from healthy tissue. If we do this, take the same images of arthritic tissue, here now we see much more irregular staining. It may not be obvious here, but there's a loss of thickness of the cartilage, and you can see a lot more irregularity at the surface. And that's because the surface layers have broken off. We get fissures in them, and then eventually they break off. And a lot of that has to do with that increased friction in the arthritic joint. And also sometimes this is another taken from another patient, but we see here that there's almost no proteoglycan left in that. And that's actually part of the degenerative process. We lose those molecules within our cartilage. And here you can see that we call it fibrillation, but basically these fissures going into the surface and then pieces breaking off. Okay, so I've talked about this mostly as a mechanical wear process. We know that there's also some biochemistry. I'm not going to go too much into detail, but what happens is when we apply forces to our cartilage, the cells actually respond to those forces. So there's many cells within our body that can actually change their activity based on the amount of force that they sense. We don't know the exact mechanism of how this works, but we know the general concept. So in cartilage, if we apply these cyclic forces that are comparable to what we would expect in the body, the cells actually start producing different molecules. So in healthy cartilage, these first two molecules, the BMP stands for bone morphogenetic protein. They call it bone because it was first identified in bone, although it also exists in cartilage. And then there's transforming growth factor as well. So these are small molecules that act like programming instructions, and they're emitted by chondrocytes under sort of normal physiological forces, and they can migrate through the tissue and interact with neighboring chondrocytes. And as I say, they act like programming instructions, and they tell the chondrocytes to produce collagen and proteoglycan molecules, so to help maintain the health of the tissue. If we dramatically increase the force, so we induce sort of pathological type of forces, that actually causes these chondrocytes to change their behavior, and they start producing other molecules. So cytokines are really a family of molecules. The most common are known as interleukins, and they actually act as programming instructions to produce proteinases or enzymes that actually start actively breaking down the tissue, the proteoglycans and the collagen. And so there's actually an interaction between the forces and the metabolism of these chondrocytes, and they can actually switch to actually actively destroy the tissue. This whole field is known as mechanobiology, and it's actually a very active area of research right now, not just in cartilage, but throughout the musculoskeletal system. But we're starting to understand more and more about this in terms of the arthritic process. So there's a change in biomechanics as the tissue degenerates. So now when we apply a force, and we're going to take a small cross section of our cartilage disc that we often test in the lab, and we're going to use computer simulation to look inside to see what happens. And this is plotting again fluid pressures. So this is this is just taking out this small cross section and plotting it. And this red region is indicating that we have very high fluid pressures. There's much lower fluid pressures out at the edge of our disc because it's essentially free draining into our bath. That's normal. It's not necessarily representing what happens in the body, but it's quite typical of sort of experimental test conditions. But if we look at the arthritic cartilage, we can see that the fluid pressures are much lower compared to the healthy tissue. And that's because there's less proteoglycan. It's easier when we apply forces to the surface. It's much easier for the fluid to flow out because there's less, of that solid mesh, so they can flow more easily, but there's also less of that electrostatic attraction. So if there's less fluid pressure, then there's more stress on that solid component. And that leads to an damage directly of that solid component, but also increased friction that causes that wear and tear at the surface. So what actually causes degeneration in osteoarthritis? Well, that's a really good question. We don't really know. Osteoarthritis is now, the research community is starting to think of it as a family of diseases that really looks the same in the end in terms of, that lower proteoglycan and the fissures at the surface, like in those microscope images I showed earlier. But they don't necessarily start the same way. And so it could, the mechanism that causes it could be different in different joints, and it could be even within, say, the hip or the knee joint, there could be different mechanisms that cause it. And we know that there's links between overloading, wear and tear. So this could be due to just very rigorous activity in patients, or it could be due to obesity or various other things. It can be due to injury. So this is probably more common in knees. So if somebody tears their ACL, it's a very important ligament for knee function. Then there's joint instability that could lead to abnormal loading on the cartilage surfaces, or also being recognized now are joint deformities. So these have been quite widely studied in hips and knees. So in hip, there's a condition known as femoroacetabular impingement. And then in the knee, this is more due to knee alignment. I'll go into a little bit of detail. So in a normal knee, or normal lower limb alignment, we can kind of draw a straight line between the knee or the hip and the ankle. And the knee lies very close to that line. And the knee force, I talked about the 2.5 times body weight. The knee is actually 2 contact surfaces on the inside and the outside of the knee, or the medial and lateral compartments, as we call them. And then in this normal alignment, that total force is distributed roughly 50-50 between those 2 compartments. But we can have a varus alignment, also known as bow-legged, or knock-kneed alignment, which is also known as valgus alignment. And the center of the knee is displaced outwards in bow-legged or inwards in knock-kneed. And that shifts the force to one side of the knee or the other. So in this bow-legged, it shifts it to the inside of the knee, as you can kind of maybe visualize here. Whereas in knock-kneed, it shifts it to the outside of the knee. So there's more force going through the outside of the knee. And patients with this type of alignment tend to generate osteoarthritis more frequently, but they also tend to develop it just on the side of the knee where that load is higher. So it could be that the other side of the knee remains healthy. So you can see that depicted here in this X-ray of somebody with the bow-legged varus alignment. This is the inside of the knee joint. You can see that joint space has got a lot smaller, and there's also some reaction of the bone. I alluded earlier to the fact that it's not just a cartilage disease. There are some changes that happen in the other tissues as well near the joint. So there's some increased bone density, as you can see from these sort of brighter white lines. In the hip, this is a deformity that is really only recognized for significance maybe about 20 years ago. And in a normal hip joint, so this is the ball on the femur, and the spherical portion you can see is joined to the neck of the femur, and we get this sort of undercut in this region here, and that creates space so that as our hip rotates and the femur comes up, there's space and it doesn't contact the rim of the socket. Whereas in this impingement deformity, we call it, as a cam deformity, there's extra materials. It's made up of bone and cartilage, but it eliminates this undercut and clearance. So now as the hip rotates, this can come into contact with the rim, and that leads to degeneration, and particularly in this region at the front of the socket. Oops. Okay, so how do we actually study these? Patients don't usually go see the doctor until they experience a lot of pain. And so that usually occurs only later in the disease progression. And so it's quite hard to study the early stages to understand what actually sort of kickstarts this degenerative process. But we can use tools such as medical imaging analysis if we can identify the patients that maybe have these deformities and study the early stages of the disease, then we can kind of understand what causes it and maybe come up with treatments to prevent it. Now, in the case of this femoroacetabular impingement deformity or CAM deformity, there was a study done at the Ottawa Hospital that found there's about 15% of the population that have these deformities, but they don't have any symptoms yet. And we don't know who's going to develop symptoms, who's going to develop degeneration and therefore symptoms later on. So we're trying to figure this out right now with some of my surgeon and radiology collaborators at the Ottawa Hospital. But this is 2 pictures showing an MRI scan of the hip joint. And you can do a lot of different things with MRI, and we call them different sequences. And the sequence means that the image will be sensitive to different aspects of the tissues that are in the field of view. And this particular sequence, it's actually very sensitive to how easily the water molecules can move about within the tissue. So it's kind of a measure of how much proteoglycan is there. And in this control, we can see sort of a lot of blue and green and maybe a little bit of red, but that's indicating that the water molecules are not very mobile because they're kind of tightly bound by those proteoglycan and to some extent the collagen molecules. Whereas in this cartilage with the cam deformity in that hip, the water molecules are actually a lot more mobile because there's proteoglycan and collagen depletion that allows them to move about more easily. So this is suggesting, in this case, that the cartilage is undergoing a degenerative process. We can also look at the bone changes, and there's some parts of the research community that think that there may be early changes in the bone that actually signify degeneration. And we know that bone will react to the loads that are placed on it, right? If an astronaut goes up into space, they lose bone mass. If weightlifters have higher bone mass because of the loads that we put on the joint. So this is a study that we did with the radiology department at the Ottawa Hospital, and we mapped out bone density in the socket of people with these hip joints. So this is actually a normal hip joint where there's no deformity, and you can see a lot of low density bone, and then this thin layer in red of the higher density bone, but it's quite a thin layer. And in people with that have this cam deformity, there's this reaction that results in increased bone density. So this is somebody that has no symptoms, but they have a cam deformity. There's already some changes in that bone, but there's more extensive changes in this person that's symptomatic. This is actually somebody that underwent surgery to correct that deformity, but they had much more extensive bone density changes. So we think that these bone density changes are maybe a biomarker of this degeneration, and maybe it's something that we could detect earlier on in the disease process. We're starting this study using positron emission tomography to look at the actual bone activity that causes these changes. So where there's new bone being created, we get accumulation of this PET tracer, and we can detect that. So you can see this kind of bright spot in the cam deformity of the femur, indicating that some kind of reaction going on. We're still sort of in the preliminary stages of this, but we're hoping that this will give us a lot more information about disease mechanisms in osteoarthritis of the hip. So how can we further study osteoarthritis? Well, it's really a multidisciplinary approach, and we have to look at things from different scales. So we have to understand the sort of loads that are placed on our joints at the macroscopic scale as we move about and do different activities, walking, going upstairs, sitting down in a chair, maybe playing basketball or hockey, that sort of thing. And then we have to translate that down into the joint surfaces and how much force is going across those joint surfaces, and then look inside the cartilage to understand the stresses and the fluid pressures in the joint, and then looking further down at the microscopic scale and understanding that micromechanical environment in terms of how does that sort of control the metabolic activity of the chondrocytes. So this is actually a very active area of research, and this is some more results from my PhD student who developed that machine that I showed earlier. And we showed that having this cyclic loading actually controls the chondrocytes to perform different metabolic activities compared to the sliding loads. And the sliding modes are actually more important for helping maintain tissue health, as we see from these changes in metabolic activity. Okay, so we can also simulate this. My master's student did some work on this a couple of years ago to look at the micromechanical environment of the cell. We didn't get to look at osteoarthritic tissues or properties, but we did look at sliding versus compression. The sliding actually creates quite a different micromechanical environment compared to the just compression. How do we translate that to benefit patients? So we can develop these musculoskeletal models. This is just a simulation showing a person's skeleton as they move about. The little red lines are the muscles that are generating the forces. So we can look at how the different joints rotate during different activities and how those muscles generate different forces. And so that can help us perform screening in terms of understanding who's generating abnormal motions or forces that could lead to degeneration. This is a study that I alluded to before in terms of the sliding motions. And this was actually, this concept of continuous passive motion was developed by a person named Salter at Sick Kids Hospital in Toronto. And he developed this, he did this study in the 1970s, and this was done in a rabbit, and they induced damage in the knee joint, so between the femur and the kneecap, the patella. And they had 3 different groups of rabbits. So one group was sedentary, they didn't move about. One group underwent continuous passive motion. And so this was an external device that rotated the knee joint without actually the rabbit needing to apply any muscle forces to do that. And then they had some rabbits run on a treadmill. And what they found was that the healthiest cartilage generated after this induced damage was due to this continuous passive motion. It was the thickest cartilage that after this, compared to the sedentary, there was a loss in thickness. And then compared to this treadmill, you can see it's not very healthy tissue and not as much staining for the proteoglycan. And then there's all this damage occurring. And so this is the kind of device that came out of Salter's work, but it hasn't really necessarily been adequately explained biomechanically. And what we think is, going back to that sliding motion studies with the nutrient diffusion, we think because you're not putting a lot of compressive loads on the cartilage and you're not inducing high friction that would damage it, but you do have that sliding motion to actually drive that fluid flow and nutrient flow into the cartilage, it's actually able to partly repair itself actually and actually get to healthier tissue. So this type of device is actually, I believe it's more commonly used on patients after a knee replacement. So not necessarily to help repair cartilage, but this is used as sort of a rehab protocol very early after the surgery to try and prevent the soft tissues from contracting and stiffening up the joint. But it has had some success in early stages of osteoarthritis to help maintain that tissue. This is another study with a knee, they call it a knee unloader brace. So this is actually people with quite advanced osteoarthritis of the knee. And you can see in these MRI images at the baseline, so the black region is actually the bone in this case. It doesn't show up very well in MRI. And this bright region, it's very, very thin here, indicating that there's not very much cartilage there. Over on the other side of the knee, though, we can still see quite thick cartilage. And you can actually see the 2 layers of cartilage in this if you look very closely. But this very advanced arthritis, normally at this stage, they would need a knee replacement, but these were quite young patients. So this research group decided, well, let's put this knee unloader brace. And so we have these very stiff bars here, except there's a spring-loaded joint in here. And then there's pins going across. You can't really see them because of the gauze that's hiding them, but they go through the skin and anchor into the bone. And the idea here is that you still have some mechanical stimulation, but the loads actually going through the surfaces will be a lot lower than if they were just walking normally. And what they found is these patients wore these braces for 2 months. They did a follow-up study where they found that you actually really only need it for 6 months. They do take it off every 2 weeks just so that they could bend their knee. But they wear this more or less continuously for 6 weeks to 2 months. And 1 year later, so 1 year after this baseline, you can actually see there's some cartilage-like tissue that's regenerated here. We don't know if it's sort of equivalent to pristine articular cartilage, but nevertheless, there's something there that's separating those bones and behaving somewhat like articular cartilage. And these patients can now move about. So as I say, this 1 year follow-up, this is long after they've taken this brace off, and they have this sort of nice soft tissue there separating. And even 2 years later, they still have this tissue. And so they can perform more or less normally. Maybe, we don't know, maybe 10 years later, this will cease behaving normally. We don't know that yet, but certainly some encouraging results here. So what about future? There's a lot of work going into tissue engineering and especially now 3D printing. So there's some groups at Carleton that are getting going with 3D printing, and this is a possibility for cartilage as well. The idea here is that you take some artificial material and you print what we call a scaffold that acts somewhat like native tissue, and then you seed it with cells. And these cells become metabolically active, and they can replace over time that scaffold that we create and hopefully generate something that looks like native tissue. And so this is the basic process. You take the cells, you put it onto, we often use hydrogels because they're easy to work with, and then you can build those up into layers into something that looks maybe like cartilage, and then you plant it into the knee joint. The challenge right now, though, is that when we create these, they're nowhere near stiff enough. Young's modulus it's just an engineering way of measuring a stiffness of a material, but this is orders of magnitude less stiff than native cartilage. So if we just took this and put it in the body, it would wear out very, very quickly. It just didn't have the durability. So the challenge in the future is really to develop better materials that can withstand the forces while the cells replace it with natural tissue. So that's kind of where the research is going in the future. So I'm going to wrap up there. I'm going to kind of give this plug for the Arthritis Society of Canada, Canadian Arthritis Society. If you want to know more about arthritis symptoms, treatments, and so forth, you can go to arthritis.ca. They provide a lot of information for that. And so I'll stop there and thank you, and happy to take any questions.
Thank you, Dr. Speirs, for that great talk. Lots of information to absorb for sure. So if you haven't submitted a question and you would like to, you may do so via the Q&A button on your screen. There are quite a few. I don't think we'll be able to get through them all, but Dr. Speirs will be provided a copy of them post-event. So our first question, are there different research findings for post-traumatic osteoarthritis versus wear and tear osteoarthritis?
Yeah, that's a good question. So there's a lot that's been done in the knee for post-traumatic. So that ACL tear that I talked about, that's a fairly common sports injury. And it's been shown that, patients that suffer an ACL tear are 10 times more likely to develop knee osteoarthritis. And that's even if they get the ACL reconstructed. It's not known whether that, that increased risk just comes from the initial joint trauma that caused the ACL tear, or it's just due to, increased knee laxity due to maybe a poor ACL reconstruction. We don't really know that. There are slight differences in terms of those biochemical changes compared to osteoarthritis. So I don't know all the details offhand, but those, the sort of the concentration of those cytokines and the proteinases that break down the tissue, they show up in slightly different concentrations compared to, say, somebody who develops knee osteoarthritis, but that's not post-traumatic.
Great, thank you. So next question. So when cartilage is lifted away from the underlying bone, is it always necessary to trim it off, such as via arthroscopic surgery?
So that's kind of hard to answer. I know in that hip impingement situation, there's often a cartilage flap where it's lifted off the bone. The surgeon, I think, will usually trim that back. It's been shown that the cells within that kind of lose viability. They're no longer necessarily living cells. And so the tissue is essentially dead. there are some options, I guess, to try and stick that back on, but you can't stick cartilage to bone very easily. There are potentially other treatments that have shown promise. So these are for like full thickness defects. They've tried, this is done more in animal studies rather than moving into applications in actual patients yet, but you can kind of drill into the bone to bring out blood, and that brings out, stem cells and platelets and things that help generate novel soft tissue there to kind of fill up the hole. So there's possible applications like that. There's a tissue I didn't talk about in the hip called the labrum. It's kind of like a ligament that wraps around the rim of it. It sometimes comes separated from the bone, and usually the surgeon will try to reattach that to the bone because it plays quite an important biomechanical role. So they usually will try and preserve as much tissue as they can.
Great, thank you. So next question. So given what you said about a lack of blood supply, does cartilage absorb turmeric or collagen taken orally?
I haven't studied that, and I don't know the literature. My guess would be no. And because if you're taking it orally, it probably, it has to pass through the digestive system with all kinds of enzymes that break down lots of molecules. So I would think by the time it gets into your system, it doesn't look anything like collagen or proteoglycan. I know there are supplements, but maybe it provides, the constituents that can be incorporated by the chondrocytes to produce new tissues. I don't know too much about the research on that topic.
Right. So next question. So what can a person with arthritic knees do on a daily basis to decrease pain and swelling and increase range and ease of motion?
So, pain is kind of the body's response to tell us to stop doing something. So you don't want to stop activity levels altogether, but basically, I would say try to do what doesn't hurt, but also, this kind of goes back to the continuous passive motion. Try and keep some motion in the knee. Walking aids such as crutches or a cane may help reduce the amount of force that goes through your knee and therefore reduce pain, but still have some stimulation. So I did talk about the stimulation in terms of controlling metabolic activity. If we completely take away that mechanical stimulation, that also results in degeneration because the cells start to think, well, hey, there's no sort of mechanical demands on this tissue, so I don't have to keep maintaining it. So you kind of have to get in that sweet spot, and we don't have a good definition of what that mechanical sweet spot is, and it probably changes with degeneration. So that's certainly an area of active research amongst arthritic researchers, but also amongst people like physiotherapists are looking into that sort of question.
Great. Next question. So do over-the-counter braces help unload pressure and improve cartilage thickness?
There are braces that are designed specifically to do that, that don't involve those pins going through your skin. But many braces are really designed for say joint laxity, maybe an ACL tear or a loose ACL or other ligaments. And so they're designed to try and prevent translation of one bone relative to the other rather than loads transmitted across the joint. So, if you have a doctor or a physiotherapist, talk to them about specifically which braces are appropriate for that.
Thank you. So you had mentioned predisposing conditions such as valgus and varus knees. So how effective are devices such as orthotics in reducing OA, and when should these be implemented?
Well, I would say the earlier the better, but once we reach skeletal maturity, so that's puberty basically, our bones are fully calcified and we can't really change the alignment of our joint without surgery. So, there are, in mild deformities, then orthotics may help, or some physiotherapy to kind of change how we move, and our muscle control strategies can help a bit. But that's something that you need to talk to a physiotherapist about, or an orthotics specialist may be able to help. But I would say it probably depends a lot on the severity of that varus or valgus alignment.
Thank you. So next question, so do changes in diet make a difference?
Yeah, that's that's something that people are definitely looking at in research. There are kind of dietary factors that are probably involved in cartilage health, but it's a very difficult question to answer because there's so many confounding factors when we try and study almost anything about arthritis, even just mechanics. You're studying somebody with maybe varus or valgus alignment, but they may have a very different diet. And so you need very large populations to study to try and kind of tease out these factors. The best we can say is that, maybe there's some link with it, but we don't necessarily know, what specific parts of the diet can contribute to cartilage health or cartilage degeneration.
All right, so next question. So does synovial fluid only act as a water bath for the cartilage, or does it have components that assist in lowering the friction coefficient?
So synovial fluid actually does a lot of different things. It isn't just a water fluid that helps with lubrication. It does do that in that, a healthy joint will actually have synovial fluid in between the cartilage surfaces. And so that further reduces friction so that you have less, solid on solid contact. But the synovium that lines the joint capsule that creates a lot of the constituents in the synovial fluid actually provides a lot of the nutrients that they move through the synovial fluid and eventually down into the cartilage, plus some of these growth factors that kind of program the chondrocyte cells. But there's another molecule at the surface of cartilage, and we call it boundary lubrication. And it's actually a very long, thin molecule with very few side chains, and it's called lubricin, and it actually attaches to the surface of cartilage, and it actually allows one surface to slide over the other without adhering. So if you have any adhering between surfaces, then it can tend to kind of rip the opposing surface apart. So this lubricin molecule comes from the synovium, and as well as some of it from the chondrocytes near the surface. So there's a lot happening in synovial fluid, and it's a very active fluid, so to say.
Okay, great. Next question. Is there a way to increase our production of proteoglycan as we age?
So again, we want to try and develop kind of optimized loading protocols to stimulate those chondrocytes to produce proteoglycan. And that depends. So we know in general it depends on that micromechanical environment, but we can't really define exactly what it is. Is it fluid pressure? Is it fluid flow? Is it compressive stress, or how much those chondrocytes get strained? We don't have a direct link yet between that and that metabolic activity. So that's something that the research community is trying to define, and they've been trying to do that for quite a few years now. Eventually, I think we'll get there. And then once we know that, then we can actually start looking at, cartilage changes with age. There is some natural loss in proteoglycan that, we can maybe think of it as very mild osteoarthritis, but that will also change the macroscopic mechanical environment, which will affect the microscopic mechanical environment. So we have to kind of, start at the beginning and go through all of this work to try and define what those optimal loading protocols are. But, I I would say stay active but don't overdo it.
That makes sense. So our last question will be, so does your research also apply to the causes of spinal degeneration and arthritis?
The general principles, yes. So arthritis does occur in the spine. You said spine, right? Did I hear that correctly?
Yeah, spine.
Yeah. Okay. So there are some articular joints in the spine is known as the facet joint. And that's just like the hip or the knee. It's both sides of that joint are lined with articular cartilage, and you can get arthritis there. In terms of the mechanical causes, that might be quite different than the joint deformities that I look at in my research. But it probably is an overloading due to, size and shape of the segments of the spine, but also, kind of activities, and especially, if patients are in sort of a manual labor type of job, or, they don't practice kind of safe, heavy lifting, and spine orientation and hip orientation. We talk about lifting with the legs, not with the waist. So that can lead to overloading of the spine. We often see that in terms of disc degeneration. I don't do that research myself, but that's kind of where it manifests itself. But also it might overload those facet joints, leading to arthritis.
Great. Thank you so much. Unfortunately, that's all the time we have today. We'll share the questions that were submitted with Dr. Speirs post-event. So just want to say thank you to Dr. Speirs for sharing your research and insight and information.
Okay.
And thank you to everyone for joining us today.
All right.
Hopefully
thank you everyone for your attention.
Yeah. We're just going to pop up a survey on the screen. If you do have time to fill it out, that would be much appreciated. So there you go. And then you can also join our mailing list to stay connected with us via the link in the chat. This actually does conclude this round of Ingenious Talks. So we will be on a little bit of a break until the fall. So if you do join our mailing list, you'll receive the most up-to-date information from us and when we'll be back. All right, so thank you so much. And we hope you have a great rest of your day and summer.